We have a distinguished panel. Dan Bolton, Dr. Dhanabalan, Dr. Jordan Tishler, and Marion McNabb.
These are now teaching doctors about the endocannabinoid system, and doctors are learning from athletes about it. So this is one of the most important things about education and changing the stigma.
Hi everybody, my name is Jordan Tishler. I'm a physician. I actually came to this from a very traditional place. I went to Harvard Medical School and I trained in internal medicine at the Brigham Women's Hospital. And spent 20 odd years doing emergency medicine, the last 15 or so for the VA. And all right, so I was talking about my time at the VA and the way in which that influenced my understanding of the lack of harms for cannabis, and that led me to start thinking about benefits. And so in my practice, I spend a fair amount of time taking care of patients who present with pain and who are on high doses of opioids. Many of those patients come to me and they say, Doc, I want to get off all of this stuff. And I must say that in general, my point of view has been, let's not focus on the getting off. Because getting off, if you think about it in this context, is really a negative, right? It's like, I don't want these things, and it puts a lot of pressure on the system, right? I'm a bad person, I can't stop taking this opiate because my back hurts. So I tend to focus us on how can we make you feel better? How can we take care of this pain? How can we increase your quality of life by using cannabis? And ultimately, by doing that, and by focusing on cannabis first, generally speaking, been very successful at getting people either off or at least very far down in terms of the doses of opiates that they've taken. And it's a low pressure thing, it's a positive thing, and that's been very successful.
Thank you very much. And to continue with our introductions, we have Dan Bolton. Please tell us how you got involved with medical activism.
Begrudgingly in high school, had a girlfriend introduce me to marijuana. I did it with her to try to prove that I was open-minded when I was being accused otherwise, because I had a very Nancy Reagan-ish point of view of marijuana at the time. And I did it, and I said, oh wait, this is not that bad at all. And then through college, I connected with friends and did a lot of marijuana in college, and I really enjoyed it, and I had excellent grades. And then after college, like most people, I just stopped using it for a good decade or more. I had a friend move and just saw a lot of room for education, and that's how I became connected in activism. Also, I worked for the Home for Little Wanderers for 11 years, working with kids in Dorchester. Just witnessed a lot of, a lot of kids unfortunately becoming imprisoned because of their use or involvement with marijuana. And then not so much the kids in Cambridge and Somerville, who I also worked with, so to see that disparity also made me want to come out and be active and educate people about, well, there's a lot of disparity in terms of how people are treated, and I also wanted to be an advocate on that level in addition to the medical component and helping people with post-traumatic stress get access and learn how cannabis can help them.
Thank you very much. And Marion McNabb, and I was just over at your, got that concept that I hope you continue to I love it. Okay, carry away.
Thank you, Kathryn. My name is Dr. Marion McNabb, and I'm the Chief Executive Officer of Cannabis Community Care and Research Network, or dubbed C3RN. So I'm a public health researcher by training, and what we're most interested in doing is advancing the science related to cannabis from a variety of perspectives, from the medical perspective, but also social justice, economic impact, and try and raise the bar of best practices and published literature in the field. So we are working to create a virtual cannabis center of excellence, a community-led research agenda that focuses more on collaboration and bringing together different industries, breaking down the silos, increasing ways that we can advance medical science and data science. in the cannabis industry. So we're about a year old, startup company, a little over a year, and grateful to be here, and thanks for the invitation to be a part of this panel. Oh, yes. And we do, C3RN has an event series that we've launched to bring together academic, clinical, and cannabis industry and consumers and patients. And so we are on our third event this month, will be next Thursday. Dr. Tishler's expert speaker on it. It will be at GTech Labs, and we'll have more information about it at the end of this event. But the idea is to have really constructive conversations about how we can raise awareness and connections at different academic institutions in Massachusetts and beyond, and increase the collaborations between academia, clinical communities, and cannabis communities.
I'd like to continue talking about how, I can see this panel being, a start of really a wonderful collaboration. So, what else can we do? Could you give we'll talk about the endocannabinoid system and how it can regulate as a meta system. So, did you want to carry it away, Dr. Uma?
So a little bit of background about myself. I'm a family physician. I'm also an occupational environmental medicine physician specialized in heavy metals. And I think I'm one of the few, I think there's 45 of us that are specialized through the American Academy of Cannabinoid Medicine. And just recently, I'm also a medical review officer. So with all of this knowledge, I never ever learned about the endocannabinoid system. I describe the endocannabinoid system in one word: life. It's a neural system in our body. We all have it. It's 600 million years old. It has evolved from the sea squirt to what we have in humans today. We've known about this system for many, many years. As it has evolved, in 1964, Dr. Raphael Mechoulam first started to learn about cannabis and identified the 3 specific cannabinoids that we talk about more often. THC, which was referred to as more of a psychoactive. I like to use the word intoxicating. CBD as non-intoxicating. And CBNs have about 1/10 of the psychoactive property. But it wasn't until 1988 that we realized that we had receptors. CB1 was discovered, which is primarily in the brain. CB2, primarily in the immune system. Again, 1988. But it wasn't until 1992 that we identified that our body made its own endocannabinoids. And what's also amazing is the first endocannabinoid that was identified is called anandamide. And anandamide mimics THC, and this is why it works so beautifully in our body. So there's synthetic cannabinoids. Very common one that's known is Marion, and it's been around since 1985. And then our body produces endocannabinoids, and we have phytocannabinoids. But all 3 of these can work with the receptors to bring about balance. And I like the 5 words that Dr. Damasio uses to explain the endocannabinoid system. He says that the endocannabinoid system is meant for us to relax, eat, sleep, forget, and protect life. And in animal studies, when they blocked this, animals did not suckle. And if they didn't suckle, they died. And that's why I call the endocannabinoid system, in one word, life. Well, that's a very good question. So in my practice, I ask my patients 3 questions. Are you peeing, are you pooping, and are you sexually active? Those are the 3 questions I ask my patients. The first 2 better be yes. And we say we'll work on the 3rd one. So yes, cannabis is a very important part. And I have not written an opioid in over 8 years. Proud of it. And thank you. And I've been calling cannabis the exit drug for over 9 years, and I've said cannabis is not an entrance drug, it's an exit drug from pharmaceuticals, narcotics, alcohol, and I'm going to add nicotine to it too.
in addition to peeing, pooping, and eating, I might add sleep in there. I think sleep and relaxation. Yeah, I mean, I think people who have post-traumatic stress disorder have a really hard time relaxing. They're hyper-vigilant. They're always worried something's going to happen or being prepared something's going to happen. Processing negative thoughts consciously or even subconsciously. So that ability to attain homeostasis for people with post-traumatic stress is just not there. So many of my clients who come to see me who have post-traumatic stress have trouble sleeping. And so much of the work of psychotherapy and getting good outcomes is helping them sleep again, because if patients can start sleeping again, then they can much better manage the rest of their symptoms the rest of the day.
Sleep is so important, folks. I cannot say this enough. People that have lack of sleep can even die, and alcohol levels, people that have been under the intoxication of alcohol and lack of sleep deprivation, it's equated to being even worse. And this is truly what you say is about cannabis. There's also enough studies now that Dr. Ethan Russo has done, and more to come, about a deficiency. And when people are deficient in their endocannabinoids, the illnesses that we're seeing, fibromyalgia, IBS, migraines, are all related to an imbalance. And this is where I see the science going, is that what I'm looking to see is how patients that can have a genetics and what is predisposing them to possibly a dysfunction in their endocannabinoid system.
Dr. McNabb, Dr. McNabb, did you want to talk about research?
Sure, it's my favorite topic. I wouldn't. I think there's a lot of room for research in general in cannabis. I think historically, because of the federal regulations and because of the fear of losing funding from an academic institution, there's been a real lack of science in the United States over the last few decades. I would say that internationally they're far outpacing the United States in terms of advancing science. And I think there are really good examples of centers of excellence in the United States and work that Dr. is doing and others are doing to advance cannabis research. So I think there's a real opportunity now in Massachusetts. It just passed the ability to have a research license as one of the adult use license categories. So it finally allows an academic or a clinical provider, or for-profit or non-for-profit, to be able to really easily, be able to actually conduct a research study with cannabis in human populations in Massachusetts. It's pretty remarkable.
Now, can patients get involved with that?
We have a monthly patient caregiver support group we've been doing for about 4 years now, and we open it up, and it's open, we post it on our website. Our website is totalhealthcarethc.com, and we hold it at the VFW. Omar, do you know when the next one is? So we'll put it on our website, and we open this up to able to change information, exchange, and destigmatize, and we call it specifically a patient caregiver support group meeting, because by law, doctors are not allowed to tell our patients how to use cannabis, where to get it. So this becomes a venue for me to open it up, and then the patients come in, and then we have caregivers, which has two terminologies: patients who's taking care of them, or also caregivers that have medicine that are able to come, and that's how we open it up to the public as well.
It's tricky. I like the idea of patients getting involved, becoming active, but I think it's a personal choice. I mean, I think there are still a lot of risks involved in putting your name out there, although the Massachusetts Supreme Court did say it's illegal to fire somebody from their job if they have a medical marijuana card and are using marijuana in their own time outside of work. But that being said, there are a lot of employers who still find other justification to try to drive somebody out of their business because they don't like, or are stuck on stereotypes about cannabis. So I think helping patients tell their stories maybe in ways that are anonymous through people who have decided they want to, put themselves out there or establish themselves as a cannabis-related business or a health practice. So I think, it can be a slippery slope, and I think want to encourage patients to be very conscious about, what they decide to share and be very informed about, or what's involved with that. Are you prepared for any sort of the backlash that might come from that? I mean, we're dealing with a federal government who still wants to get access to patient lists in the states who have medical marijuana programs for who knows what. We don't know. So I think there are still risks out there. I think it's also very important for us as practitioners to protect the privacy of our patients and really make sure, if they want to be active, that's their personal choice and they're making it very consciously and with information.
You bring up the point about personal protective information. Actually, cannabis is not protected for patients at all because it is in Schedule 1. And there's two types of drug testing, folks. There's federal and non-federal. And regardless of the employers, it's up to the employers not to test. But if you work for a federal site and you have a federal job, you are guided under those guidelines and you are screwed. There is no allowable positive for THC from a medical patient. That's just something that's federally still illegal.
And Dr. Tishler, you could talk about the VA.
I'm not sure there's much to say. Everything Uma said was exactly accurate, which is to say that the federal government maintains the right to randomly drug test any employee, and if you test positive, then there's an administrative procedure. Thankfully, it's not immediate termination. You go into counseling, and depending upon the outcome of that, you may end up on sort of an administrative reassignment, but ultimately this is moving towards your dismissal. Unless, of course, you rehabilitate yourself, which as a patient, that's not really quite the right idea, is it? Yeah, the best idea is, at least if you're a federal employee, is keep this on the DL and cross your fingers that that you don't get tested, and perhaps stockpile some urine in your freezer, wait from a time at which you are not using, or some such other thing like that. Probably not my best advice.
But we love it nonetheless. Now I had, I was starting to, this herb is so impressive that it got, and I backed into studying about other herbs. Mainly because I was saying, oh, my grow is so stinky and I have all these people coming over, I'm supposed to be a respectable lady here. What am I going to do? So they said, grow, some really smelly herbs outside, like rosemary and sage and stuff, and they're awesome too. So it occurred to me we had synthesis, antithesis, and we were going to try maybe to get to synthesis, antithesis, synthesis. Okay, thesis was when all medicine was herbal. Okay, and now we're into the antithesis where everything is pharma. And if we can get to a synthesis where we have a holistic with herbs and, minimal pharma, because I don't know if that's biocompatible. Now, what do you say about biocompatibility in other herbs? I mean, medicine.
I think cannabis plays pretty well in the sandbox. It certainly, as we've talked about, has led to the ability to decrease some of the medications that people take, but there are many other medications that people need to take, and cannabis works well as an adjunct to that. There are some cases where there are some relative contraindications, particularly to CBD more so than whole plant cannabis, but again, these are great medicines to use together, and they often work very well together. For example, SSRIs, which some people need for their depression, work really well, but they also come with side effects. People talk about feeling like a zombie. Adding cannabis as an addition can really alleviate some of those side effects from the SSRIs. So yeah, I think that this just requires thought and care.
The other thing that we're able to see is that actually making people aware of hydration, right? I'm a big pusher. People have heard me say hydrate before you medicate. Dr. Uma says this because honestly, this is about basics. People don't drink enough fluids and people are not pooping enough. because they're not getting enough fiber, or the medications that they're taking are not allowing them to poop. Many people are on oxys or all these pain meds, these opioids that cause constipation. And they're afraid, and then they're on blood pressure medicines that cause them to pee too much. So they're afraid to drink. So I go back to the basics of some herbs of chamomile. I tell people, do chamomile tea. It's a very natural anti-anxiolytic. Lemongrass, holy basil. These are all natural herbs that have been around. I'm from India, so we've incorporated turmeric, ginger, these basic things that we can all get access to, and they're legal. And this is what's going to happen, is people are going to start to say, what else can I go to? Not a synthetic pill. And that's all these prescription meds are. And I've been able to even get patients off of meds that have been on meds for over 30, 40 years. I have a guy that lost 110 pounds and using only cannabis and was on God knows how many pills. Completely off of everything.
Just wanted to speak to the interaction between certain drugs, like, and maybe for Dr. Tishler, you could speak to this further. I was reading a study that said adding cannabis as a supplement with opioid prescription, not that I think you can treat pain without opioids, and I think that is a great goal. But I also read a study that said it can increase the analgesic effect of the opiate with reduced amount of prescription, so you can give a lower dosage and reduce the risk of someone becoming addicted.
So the best numbers on that look like you would need roughly only 20% of the amount of opioid if you add cannabis. And the compelling part of that for me is that the risk from of both addiction as well as overdose from opiates is linear, meaning for every milligram more you take, the risk increases. So the point being is that every milligram less you take, the risk decreases. So if we can knock off 80% of somebody's need for opiate, even if we're not taking it down to zero, we've made a huge difference in terms of their risk to both addiction and overdose. So yeah, that's a huge piece.
Yeah, I think definitely Dr. Tishler and Dr. Uma would know a lot more of the clinical medicine side of it. I look at it from a population perspective, from a public health perspective, and you know, and thinking about not only the importance of reducing the intake, but at all the other interventions that are associated with substance abuse and all the other factors that are associated with addiction, and how do you ensure that somebody in that substance abuse program really isn't tested for THC, and that those people are educated and guidelines are changed at a structural level, so that would facilitate clinicians facilitate sort of rapid introduction of these types of interventions and research actually in the practice. So,
many years ago, my wife, who's also a doc, was talking to me about one of the policies in the clinic that she runs at Brigham, or ran at the time. And what was really interesting to me is that they were drug testing their patients for opioids, not to see if they were abusing the opioids, but because they wanted to make sure that the patients were taking the opioids that were prescribed rather than reselling them. And I was like, oh my God, that just kind of blew my mind, like we have to worry about that, but apparently we didn't. I think it would be kind of cool someday when we're testing patients for THC to make sure they're taking their cannabis, right? So that we don't have to worry quite so much about the opioids creeping back into their lives. Anyhow.
As a matter of fact, I was saying the DPH should be in the streets throwing bud at the DPH should be in the streets throwing bud at passersby.
It's actually interesting. We're going to be doing a study that actually is showing that this is one of the things as a medical review officer that I'm seeing is that people that test positive for THC are negative for opioids, meaning they don't want their opioids, doc. So just say no to your doctors is my whole message now. Just say no to your doctors, because every time that you tell them that you're using cannabis, they want to throw another opioid prescription at you. And this is going to clearly come out. We know that when we have a medical marijuana program With the dispensaries available, in 2 years, 25% reduction, 33% in 3 or more years. So it's not just having the program available, you must have the dispensaries available to have the access as well.
I was going to tell a funny story. So I go into surgery, right? I have my bunions done. So you're supposed to tell your anesthesiologist, you know, if you're taking any cannabis. So I was saying, yes, I do RSO, you know, sublingually, morning and night, and I smoke, you know, upon social occasions. So he said, and how social are we? I said, very. and when I was doing my cataract, so the surgical, I'm on my gurney, and the surgical team was in front of me introducing themselves, which I thought was quite nice. And I said, oh, you're medical, let me explain the endocannabinoid system. And what cannabis? Marijuana. Oh, okay. And so I explained it to them. They said, and that anesthesiologist said, oh, everybody knows weed calms you down. So I said, I'm in good hands, carry on. So, and then there was, so I did a pre-op exam, and I, you know, said I was on, okay, you're healthier than a horse, and what meds are you on? And I said, cannabis. I can't write that down. I said, you have to. This is a data point. You just declared me, you know, healthier than a horse, and I just said my, you know, meds are cannabis. Talking about for future research source, tell me where research is going to go.
Yeah, I think there could be really, really exciting things. I think, you know, given the fact that there's a research license here and there's so many universities and experts here and clinical providers, I mean, this is a medical tourism site of the world. I mean, the research could go, you know, very far in multiple directions. I think, you know, personally at C3RN, we are most interested in opioid epidemic. Massachusetts is 250% higher rates of overdoses and hospitalizations than other states in the United States. I think from a variety of angles, I think we can actually put those findings into practice. Like I said, like changing particular guidelines or really putting political pressure on trying to use funding and make funding available for this. I think there's a lot of really life sciences research, clinical research, you know, plant science research on terpenes. I think, you know, just once you open the floodgates, and now in June, people will be able to apply. I hope it would be uncapped. I think we've been really, it's been a shame that there hasn't been any support for research. And there's a, you know, significant anecdotal and some preclinical trials and exciting things happening around the world. I think the science and functions of cannabis and how it works in the endocannabinoid system is extremely complex. So everything from, you know, cell biology to, you know, public health pie in the sky that I'd like to infinite possibilities. I don't know if anybody else has other exciting desires for research.
I'm just going to say I've got 2 years worth of patient data sitting in my desk that if you want to get at it, we can talk about it.
This is an area I'm really curious about also. I mean, going to the State House with MassCann and seeing how obstinate a good majority of these politicians are, I just can't imagine, like, what is it going to take for them to open up the doors for research to happen. I mean, as most of us know here, research has been horribly restricted in the United States since the 1970s. I think research is what we need. We need more information. We need to educate people. And I guess my experience has been the politicians just don't want to hear anything other than what they already think they know. And how do we break through that stubbornness? Because that has been one of the most crazy-making parts of being active for me.
It's a very good question. I think there are some politicians that maybe oppose research, but I think particularly in Massachusetts, the Cannabis Control Commission has been one I would like to applaud them for the amount of open, transparent work that they've done to prepare these regulations and to have the foresight to include research licenses as one of those categories. I know that, you know, from attending several of those meetings and watching, when I couldn't be in person, I think there is a real strong awareness and commitment that there is such intellectual capital here in the Commonwealth. Clinical expertise, a variety of specialties, over 100 universities. I mean, I think from my perspective of how I've watched the regulatory design process, I think they're going to be really supportive, and I think it's a great opportunity, and I think I'm really impressed personally with the Cannabis Control Commission and how they could embrace.
So in the meantime, what about the crowdsourcing? Everybody has tons of anecdotal evidence. How do we, because we've been waiting for the double-blind studies, but we also have crowdsourcing. So talk about that.
First of all, I don't like to use that word anecdotal, and I think as cannabinoid people, we should stop using that word. I've asked this question, I'm going to ask it again. What part of zero is not evidence? Zero. Zero is evidence. I've asked this and people have not had an answer for me. So it is evidence, and we need to stop using the word anecdotal because that's just confusing people. Research is out there. There's a thing called the World Wide Web. Go to it. And there's a thing called PubMed, P-U-B-M-E-D. Research has been done. Over 25,000 articles are out there. Don't let them fool you by using that word and saying that there's no research. Stop it now. Say, go to this web and get this information.
Well, I hate to, be picky, but what I was thinking of is there's the double-blind scientific, white coats, but then there's the rest of us, and that's valid too. Our experiences are valid.
The experiences are valid, but they don't lead to under greater scientific understanding because there's no way for us to interpret between each individual's experience and each individual's actual use. So the joke is plural of anecdote is not data. So, the point is what we really need is folks who have had experiences with cannabis to get involved in participating in more rigorous ongoing studies, the kind of studies that we hope will be forthcoming. I absolutely want to echo what Uma said, which is it's very political at the moment to say things like, well, this sounds like a lovely idea, but we really don't have enough data on it. Baloney. Cannabis is without question the most researched substance ever. Now, of the 26,000 plus studies that are out there, not all of them are great. Not all of them were looking for benefit. Most of them, funded by our federal government, were looking for harms. Ironically, most of those didn't find it, which is valid and useful as well. But the point is that in all fields of medicine, we start with a certain amount of information, and then we work from that information to take care of people. And we know that it's not the final story, and that we need to continue to do research, and research is in fact spurred by our experience with these patients. But we don't stop and say, sorry, we can't treat your heart disease because, we haven't done enough studies. We work with what we have now, we do the best we can for patients now, and we try to move the ball down the field, and we revise our approach and our understanding as we learn more. And that's the responsible approach to where we are now.
I love that. That's fantastic.
The other thing that we have data. We have data that's going to be published soon. I have over 1,700 patients. When I started writing recommendations in Massachusetts, every one of our patients is in an electronic medical record, and every patient I certified was certified for not more than 6 months. So every patient, I have data on what they started out with ICD-9 and ICD-10 codes, and every patient, I have their PMP. So that's objective data. They can't tell me this is not what they were on when it came into you, and this is what they're on 4 years later, and this is how much their weight has lost, and this is how many pills they're not taking. That's objective data. So this has to get published, and now with these research opportunities, I do plan on publishing these data. It's out there, and it will come out.
I think some of the trouble with the research that's there is a lot of it's correlation. And the people who have a stake in one side or another, they can use those correlations to try to create a certain impression and try to make it seem like there's a causal connection. For example, a lot of research has been on cannabis says, oh, if you use cannabis, you're going to be at increased risk for mental health or psychosis. So a mentor of mine, Dr. Mitch Earlywine, who I studied with back in my bachelor's days, who now also speaks for NORML, he said, he revealed that a lot of these pieces of research had, to get enough subjects, you had to go to an area where people were smoking marijuana, and that was the medical marijuana patients in California. Now, what are the medical marijuana patients in California smoking medical cannabis for? Cancer, other sort of chronic health conditions that they can't get over. So if you have cancer and you're not getting cured, you're going to be depressed. Depression is learned helplessness. And so you're depressed, those people in those studies were depressed because of their conditions, not because they were using cannabis. So this is where a lot of data can be skewed to make one argument one way or another. And I think that's where we do need more rigorous studies, like longitudinal studies, which shows like, all right, let's get, what are the factors that, we can identify ahead of time so we can rule out certain external variables.
Exactly right. But by the same token, we do have some of that research. For example, the New Zealand study, which followed people from the early 70s on, and showed that people were able to, so the other question is, when you do a study, what are you measuring, right? And so you can measure all kinds of endpoints, like do their brains change when we look at them with an MRI scan or something like that. But this New Zealand study is a really interesting one. It wasn't about medicine at all, it was about recreational users. But what they did is they followed a bunch of people who they considered heavy users for 40 some odd years and asked the question, well, what happened to them, right? Were they able to be employed? Were they able to hold that job? Did they have significant relationships in their lives? Were they good parents? Those sorts of things. And the answer was, yeah, they, compared to other non-users, they had normal sort of lives. That to me as a practitioner is very, very reassuring, right? That you can say whatever you want about them from your moral point of view, but ultimately, if they end up with a life that is satisfying and fulfilling, how can I argue with that? I like to look, this is a saying, and again it comes from my wife, about correlations. The correlation is two things might be related to each other, right? So doorknobs and doors, right? Well, every door, more or less, has a doorknob. Does that mean that doorknobs cause doors? No, they don't. Okay, so that's the fallacy of correlation.
Would you all like to do a last sentiment?
We have some questions.
Oh, question.
Ask a question.
Liz?
In regard to the CBD oils that are... Hi, thank you. In regard to your CBD oils that are, there's no THC in them, first of all, every group out here is selling some sort of a CBD oil. Are there others that are better than some of the other? Non-THC. Okay. Secondly, how long does it take for that to get into your system? And third, if it doesn't have any THC in it, can you pass a drug test for the federal government?
Yes, you can pass the drug test. THC is what they're looking for. It should be absorbed relatively quickly if you take it orally, within an hour or so. But I think one of the things that I tend to say in response to that sort of question is there's not a whole lot of proven benefit at this point to CBD in its purest form. There are certain use cases and there's some laboratory data, but that most of those positive studies have been at doses of CBD that are well beyond what anybody is sort of selling or using here. So when we look at cannabis use, CBD use specifically for anxiety, for example, or as an antipsychotic, typically the doses are between 800 and 1200 milligrams per day, which is sort of roughly $50 a day worth of material. Nothing that you're seeing out here comes close to that.
Okay, so the stuff that's out here, one of those little bottles is like 50 grams. That's what I'm seeing. That you're saying that we need at least one of those bottles per day for any stress-related issues or pain. This is the one without the THC.
Ladies and gentlemen, we are coming into the final hour of the 2018 New England Cannabis Convention. Thank you all for attending today. We still have some great speakers wrapping up the day, and I'm sure there are some fantastic deals amongst our vendors and sponsors.
I think part of your question there is that the lab studies that were done with stuff that was verifiably CBD. The bottles of something labeled CBD out there, I don't know what's in that. The FDA a year ago sent cease and desist letters to 4 major CBD manufacturers simply because, quite frankly, there wasn't any measurable CBD in their CBD labeled product. So the point is, I can't tell you what you're getting out there. If you were to go to CW Hemp on the web and buy their bottle of 1,000 milligrams, which would cost you, I think, actually way more than what I had just said, because it's branded, then yeah, you'd have to drink that bottle every day. So it becomes quite unattainable, financially.
Okay, so thank you. That answers my question.
I was just going to say, in terms of CBD product, you said the Charlotte's Web, they do have an Everyday Advance, which is the very higher potency. I've used it myself. I haven't done it probably those dosages, but I have noticed an effect. I haven't measured it clinically or anything, I use other THC, so it's hard to decipher exactly how much the Charlotte's Web Everyday Advance has helped me. But if I take it alone, I can feel somewhat of an impact. I mean, there are also trace amounts of THC as well. But
you have a great anecdote, right?
Yeah.
And so, at the end of the day, what do we make of that? I don't know. I'd feel better.
Yeah.
Right?
Yeah, right.
One important thing for people to understand is that there's THC and then there's CBD, which we talk about, but there's the system with the receptors, and CBD does not, I will repeat, CBD does not work with CB1 and CB2 receptors. THC does. CBD, I tell people, basic, go home, buy 3 tablespoons of hemp seeds every day. Start there. That's your CBD. Get your hemp protein. Get your hemp oil. Start right there with bringing down inflammation in your body. That's easy. It's cheap. I know I can get it every day. We don't know what people are getting. We don't know what the testing is right now. Start with the simple things that are out there. You can order that online, and you won't be testing positive for THC if you're going for it. Now, I'm going to say this with a word of caution. We don't know what's in a lot of the CBD. So, if you are a DOT driver, I would highly recommend that you go get a P test done before you have to go get another P test done. Because God forbid you're positive, you have some time to stop taking the products. Because people don't realize that there's THC in some of those products.
This is a really good point, and I just want to point out that you can go to Amazon.com, and for $5 you can buy a urine dipstick that's exactly as accurate as anything anybody's going to use. And I tell my patients, look, if you know you have a test coming up and you're worried about it, yeah, you can just go buy the test, and every week you test yourself, and when you know you're clean, you're good to go.
Again, with drug testing, folks, understand that it's dependent on your body. It's not just time. There are people that can test positive much longer, and I've seen this. People that are heavier, men versus women, versus what medications. So drug testing, this is what I do as a medical review officer. We know that it can vary. So this is what's kind of sad. People that use cocaine or use your opioids, and you could pass off and say, yes, I used my opioids, they're good to go. But if you stop using your cannabis, you can still test positive, because this is part of what your body needs, folks. There is no opioid deficiency, there is a cannabinoid deficiency.
On the topic of CBD products, the standards in terms of measuring, I think, just aren't necessarily all there. I think we need a lot of room. There's a lot of room for improvement. And And I think going to reputable sources is probably better than going to someone who makes claim. I mean, people can make any sort of claim. I've connected with people over the past year and things who say, yeah, this is CBD only and da 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 da. And then later on, I get to know them a little bit better. They're like, oh, it's actually just whole plant. I just say it's CBD to get around the regulation. So you don't, if you're intending not to use THC and you're afraid of, and you're going to get drug tested, be very careful about what sort of CBD product you buy and buy from reputable sources.
One other thing I want to add on the CBD note is that when we start to talk about using CBD at higher amounts, we also have to remember that CBD is metabolized, unlike most of the rest of the cannabinoids, through the enzymes in the liver that are responsible for metabolizing the vast majority of conventional medications. So what this means is that CBD, more so than just regular cannabis, can interact with conventional meds. So depending upon what you may be taking, this can be dangerous. Anti-epileptics are one, some but not all of the blood thinners are another. Right, particularly the 3A. But yeah, so the point is, it needs to be done with a little thought if one is taking other medications.
One last question, we wrap up.
Hi. So I already asked both of you this question with regards to cannabis server training. And after speaking to you and also some of the dispensaries that are here today, I see that we'll just call it X training right now because there is something exclusive for the medical field as well as for eventual establishments such as a pop bar or a yoga studio or an event where you can have a temporary license. And then the dispensaries as well, where some of them feel that they don't necessarily have to send a patient or a consumer to a doctor, whereas at sometimes, it's the other way around. And there's sort of like this middle ground. I don't know if there's any barriers that physicians feel between the dispensaries and that sometimes, like what is it, like you can't describe it or something like that. And so that's the thing. I asked, please, can we try to get some type of cannabis server training going on, like talk about this? Because the idea is, right, is that there's already enough medical evidence, but the thing is that what is the government going to listen to? So like New Zealand, Colorado, yes, but at the same time, let's try to prove that this is a substance that has a low amount of abuse. For the cannabis server training, I feel like a lot of this information is here and there, and I feel like if we just put all of it together in like a unified group, so that way there was no argument. I just didn't know like what your thought was. Do you think that's maybe like an easier battle to win right now than, like, do you feel like it'd be easier to get cannabis server training? Alright, sorry, just one last thing. I think it's the Dram Shop or something. I was just talking to Will Loosier. He mentioned how it happened with alcohol, and the problem with cannabis is that there was alcohol established. There was bars first, and then this happens like tip certification as a response to like prevent lawsuits. But we can't. I don't really feel like we can have like social consumption establishments until we have cannabis server training. I also feel like this is something that could benefit like dispensaries and also help bridge the gap between doctors, where it's like there would be like a unified information. I just feel like, do you think this is important and this is something that we should address, like, especially together, like?
Yes, this is definitely a conversation we definitely have to have. But it's 5 o'clock now. I'm going to release these people, and we're going to continue this conversation because we do want to know how are we going to get cannabis into the hospitals and the retirement homes and hospitals.